Hello everyone and welcome to this week's Family Matters. It's the first of a two-part series. I sit down with Dr Dermot Kearney. He's a UK cardiologist who's actually been involved with the abortion reversal pill. So we're going to have a little bit of a chat about his experiences and insights. As I say, this is part one, so you'll have to tune in next week for part two. But enjoy this first part of the discussion. Well, we're facing a very important issue here in New Zealand. The Ministry of Health has put out a position statement saying that the action of abortion reversal is unethical, and they're saying to medical and health professionals here in New Zealand that they're not allowed to effectively advertise or sell the service. Now, this is unusual for a number of reasons, and the why is what we're going to discuss today, because I am very pleased to have on the podcast Dr Dermot Kearney. He is a cardiologist, he is a general physician, he's the former head or president of the Catholic Medical Association in the UK, and a man who's been dragged through the courts around this very issue of abortion reversal pills. So, Dr Kearney, welcome to the show.
Thank you very much, Simon. It's lovely. It's an honour to be talking to you.
I wonder if we might start, if you wanted to explain the journey you've been through, as I've just hinted. I mean, you've lived it, but I've just hinted to viewers that you are a medical doctor. You have prescribed what's known as abortion reversal pills, or effectively progesterone, and then you were dragged through the courts in the UK. So tell us about your experience, then we might tease that out a bit further.
Yeah, it wasn't exactly dragged through the courts. It was dragged through summoned by the medical regulatory authorities after I suppose, false complaints, false witness by the main abortion providers, Mary Stopes International, and also the Royal Obstetricians, who didn't like what we were doing. Just to backtrack a little bit, I'm a member, as you said, of the Catholic Medical Association, and we were approached initially in 2014, actually, by one of the pro-life organisations in the UK called Life, a wonderful man called Jack Scarisbrick, who had heard that there was emerging from the United States a service whereby women who had taken the first abortion pill would change their mind if they received progesterone treatment, could actually save their babies by preventing the ongoing effect of the first abortion pill, mifepristone. So he brought this to our attention because he'd heard some rumours. And the reason he knew that was that women were already coming to his organisation seeking help. They had already taken the first pill and decided that they wanted to keep their babies, and they came to his organisation and some other pro-life organisations wondering, was there anything that could be done? And he looked into it. So he brought this to our attention. None of us knew anything about it. There was about 12 of us at that first council meeting that he attended. And we said we'd look into it. I have to admit, I and all of the others were very sceptical. We thought, first of all, is there really a need? Do women really change their mind? But we thought, well, obviously he's come across some who have, so it's certainly worth looking into. We wondered, though, does it work? Because we know that mifepristone is quite a lethal drug. It binds very avidly to progesterone receptors. It has quite a dramatic and quick effect in inducing miscarriage, even though it is recommended by the abortion providers that a second pill, misoprostol, should be taken 1 or 2 days later to complete the abortion. But in the vast majority of cases, the baby's already dead by the time the misoprostol is taken. So we wondered, could it actually be effective? And the real concern that we had was, even if it was effective, even if some babies survived, was there any danger that the babies who had been exposed to mifepristone at the early stage of pregnancy, could they have some long-term damage done to them, even by teratogenic drugs that can cause damage to the developing embryo and the developing fetus in early pregnancy? But we said we'd look into it. 2014, there wasn't a lot of information, but there were some case reports coming from the United States. We didn't have a lot of information, and we still remained on the sidelines. 2018, and a few years later, another pro-life warrior called Claire McCulloch from Good Counsel Network, based in London, another pro-life organisation, pleaded with us. She came to our annual conference and pleaded, could we please help her and her organisation, because more and more women were coming to them seeking this help. I was elected president of the CMA at that annual general meeting. And I promised her that I would look into it in more detail. I would go to the United States. I would meet the pioneers of the service, the abortion pill reversal service, primarily George Delgado. He was one of the speakers at the U.S. annual medical conference, Catholic medical conference that year. I went to meet him and some of the other people who'd been involved in the service. I read everything I could, both on the positive side, that those who were in favour of abortion pill reversal, but I also realised quite early on that there was an opposition. So I read everything that they had to say about the issue. The deciding factor for me actually was, it may surprise many, because the New York Times is not exactly known for its pro-life stance, I think. I could be wrong on that. But they actually had a very fair, very well-balanced article published in 2017. I can't remember who the author was. It was a woman. And she was looking into this whole new, relatively new area of abortion pill reversal. She called it the new front line on the abortion war, abortion pill reversal. And she interviewed George Delgado. She interviewed a guy called Daniel Grossman, who was the biggest opponent of abortion reversal. But she interviewed a few other people. She interviewed a woman who had had a baby and attributed it to the treatment she had been given with progesterone after she had regretted taking mifepristone. But the person who actually influenced me the most was a guy called Harvey Kleiman, Professor Harvey Kleiman from Yale Medical School, who described himself as being pro-choice. He was a professor of placental research and reproductive studies. And his opinion was that this reversal treatment with progesterone, because of the effect that mifepristone has in blocking progesterone receptors, that if you can antagonize the antagonist, give the antidote, if you like, progesterone, he said this makes absolute biological sense. He said, if I had a daughter who was pregnant and accidentally took mifepristone but wanted to keep her baby, there's no doubt I would give her progesterone in high dose for at least a few days, and I bet you something it would work. So when someone of that caliber made that sort of statement, it convinced me that, yes, well, we got to try and do something about this. So the question was then, how could it be done? And I'm very much obliged to my colleague, Dr. Eileen Riley, who is an obstetrician in Glasgow, who was the first person in the UK to prescribe abortion reversal. She realised from the start that you don't have to. Suppose we were jumping on the bandwagon of what the abortion people are doing to some extent. They do most of their prescribing now without actually seeing the patient and face-to-face. They do it all by telephone and telemedicine consultations. So she realised that once we have a knowledge of what we're prescribing, once we understand the pharmacology and the physiology of how these things work, we understand the protocols that are recommended by those who have been using it already. Because by this stage, there was a formal program, abortion pill reversal program, set up in the United States since 2012. And they had at that stage a few hundred successful cases. It's now over 5,500 since 2012. But once we were following the protocols, which we knew to be safe, then she felt that we could, if women contacted us or could get in contact with us some way, we could contact a local pharmacy for them, check first of all if they had progesterone in stock, and if they had it, would they be happy to accept an initial email prescription from us, from myself, from her, from other doctors who might want to prescribe the medication. And then we then always promise that we will send the hard copy of the prescription the same day or the next day, the first available post, so that pharmacists would have it on their records. And this worked. And I found to my amazement that pharmacists were very obliging, very prepared to do this. And initially it was slow. Eileen got most of the cases that were coming to us. We both registered with the Abortion Pill Reversal Network based in Ohio in the United States through Heartbeat International. They had us on record as doctors in the UK who were willing and able to prescribe the abortion pill reversal. So if a woman from the UK contacted their service, their helpline, they were able to say, oh, we know a doctor in your area that might be able to help you, and then they would contact us. That's how it all started. And Eileen and myself were happily doing this. We started, she did the first case in May 2020. I did my first case towards the end of June 2020. And this was going on nicely. We were into 2021. I had spoken about this actually. I spoke to an all-party parliamentary body in the United Kingdom Parliament. There was an issue. They were debating the issue of pills by post and pills at home and concerns that were raised. And they asked me as a medical person, to just mention from the pro-life point of view, what concerns do we have about giving these abortion pills to women at home without any face-to-face consultation? And they said, oh, by the way, while you're on, would you mind talking to us for a few minutes about the abortion pill reversal service? And I was very happy to do that. This was in March 2021. So we were about 9-10 months into the service at this stage. A number of babies had been born, so I was happy to tell them about the successes. I also told them about the failures and the devastation when the treatment doesn't work, which is always heartbreaking for the mother and also for myself and families involved. So we gave this, and we got lots of questions from peers in Parliament. Oh, thank you very much, and this is very interesting. And then the next major presentation was at the General Medical Council itself. I was, as Catholic Medical Association president, I was representing the CMA on an equality, diversity and inclusion forum that the GMC had set up the previous year, or 1 or 2 years before that. And every so often we had these meetings, sometimes face-to-face, sometimes on Zoom. And this was a face-to-face meeting where we had to go to London and say a little bit about our organizations and explain to the other bodies. So there was all minority groups of doctors represented. There was Catholic Medical Association, Christian Medical Fellowship, Sikh doctors, Jewish doctors, Islamic doctors, LGBT doctors, disabled doctors, women surgeons. So a whole variety of different groups. And each one said 2 or 3 minutes about the work they were doing. I gave a report on them. I said a number of our members, I didn't say who or how many, are providing an abortion pill reversal service. And this is what we do. And I explained just briefly the basis of it. And the chairperson of the GMC forum said, thank you very much, Dr. Kearney. We'll now move on to the rest. So they actually knew about it. And that was at the start of April 2021. And then on the 28th of April, it was a Wednesday, lunchtime Wednesday, just afternoon, I got an email from the GMC, and Eileen Riley got one exactly at the same time to say that serious complaints had been made about the activities that we were involved in providing this abortion pill reversal, or what they call so-called abortion pill reversal service to women. And the complaints had come from MSI and from the Royal College of Surgeons. In my case, it was both of those. In Eileen's case, it was just from the Royal College of Obstetricians, not Surgeons. She didn't, I think, have a specific complaint from the MSI because they had obtained my name and my details from one of their clients. So we had to inform the pro-life organisations around the country that this was happening, because we were ordered to attend a medical practitioners tribunal hearing 2 weeks later on the 12th of May. So we had to stop our activities at that time. We had to inform the pro-life organisations because a number of them were sending some patients to us, some clients to us, who would actually approach them first, and then they would refer them to us. And that was on a Wednesday. By Friday morning, I didn't know them very well, but Christian Concern, who are a wonderful pro-life organisation, a wonderful Christian organisation, not Catholic, evangelical Christian, but we worked together on the abortion pill problem with Parliament. So they came to our aid immediately, and by Friday morning, their chief executive Andrea Williams had organised a Zoom meeting between myself, Eileen Riley, herself, and 2 of their leading legal barristers to say that they were going to fight this. Because our initial reaction was, it's the GMC, like, we're powerless, we can't do anything. And she pointed her finger down the camera on the computer and says, no, we will not accept this. This is unjust. We're going to fight this. And she did. And with Christian Legal Centre, which is the legal wing of Christian Concern, they offered us help, and we took it from there. We attended the first tribunal. We had already got an expert witness, which is interesting because Mike Phillips, who was the chief barrister with Christian Legal Centre, he said, "Oh, I know somebody who's a well-renowned obstetrician. He's given expert witness on various things that we've done in the past. He's not a Christian. He's not a Catholic. Don't even know if he's on any religion. He does abortions, but I think he might be interested in looking at the allegations that have been made, because in my case, there was 10 specific allegations, which we might talk about in a little while. So within 2 days, he had this expert witness on board, who did look at the allegations, and within a few days had given his expert opinion, non-biased, so there certainly wasn't any conflict of interest on his behalf. He pointed out his duty was to basically provide the truth to as he saw it, to his expert opinion truth to the GMC, to help them to make a decision, and to the tribunal as well. So his evidence was presented. At that stage, we didn't get any of the mothers involved because we didn't have time, but we knew that would be key, that we, seen as one of the allegations against me was that I was allegedly enforcing my pro-life beliefs and also my Catholic beliefs on vulnerable women. Obviously, there was no evidence for this, and it turned out that they eventually had to accept that there was no evidence for this. But that was one of the allegations. So we knew that getting at least some of the women, we could have got witness statements from about 40 at that stage, but we got 10 different ones, which came at a later stage when we appealed to the initial tribunal, because the tribunal found against us. The GMC wanted to suspend myself and Dr. Eileen completely. They wanted us basically to not be allowed to do any medical practice in the UK for a period of 18 months. That was the maximum penalty that could be imposed. So not only not doing the abortion pill reversal, but not doing cardiology in my case, obstetrics in her case. The tribunal considered that, and they felt that was probably disproportionate. Because bear in mind, this was 2021. This was during COVID. There was appeals all of the time from people like the GMC and from other organisations for doctors to come out of retirement to fill up the gaps because of the COVID crisis. So they felt it probably would be disproportionate to have two experienced doctors suspended completely from any medical service, but they ensured that neither of us would be able to provide the abortion pill reversal. So in my case, the main condition attached to my ongoing practice, so I was allowed to retain my licence on the condition that, number one, I did not prescribe, administer, or recommend progesterone for abortion pill reversal. And also I was stopped from doing any private work, which I don't do anyway, or any voluntary work, which I was doing. I used to go as a medical doctor to Lourdes and help with invalids, but I wasn't allowed to do either of those unless I had express written permission from the GMC, which they probably wouldn't have been too happy to give, just in case I might be sneaking progesterone somewhere into someone's soup or tea or something. So we were basically stopped from doing it from the 12th of May. So I became the first doctor in history to be banned from saving lives, because even up to that point, we had enough evidence to show that this was a life-saving service that we were offering. And that first year, 32 babies were saved. Not all of them had been born by that time, but by the time our 32 babies were already well on the way, and 32 babies were born, either had already been born by that stage or within a few months of that ban being put in place. 20 myself. Eileen, I was more available than Eileen because she was often in theatre and not always available to accept calls. But between the two of us, we had 32 babies saved. There could have been more. There were others that initially were very successful, but for various reasons, usually due to coercion from boyfriends or husbands or family members, their mothers later on decided to have a later abortion, even though the initial APR had been successful. So we had a success rate of 50-55%, which we've maintained to this day. So we were stopped from doing it in May 2022 and May 2021, and with the initial plan that this was going to remain in place for 18 months, and then it would be reviewed. By law, it had to be reviewed every 6 months, but it was very likely that they were just going to retain it 6 month after 6 months and not let us back into it until the whole issue died down. But Andrea Williams and Christian Concern and Christian Legal Centre had very different ideas, and they decided no, they were going to fight this, which they did. I might stop at that point in case you want to interject with some additional questions at this point.
No, it's absolutely fascinating, which is why I've just let you speak. I mean, if we just take a step back for a moment, within the medical sphere, it's not unusual for doctors to be prescribing something, we'd say in New Zealand, off-label. And I know you're in the UK, we're in New Zealand, but our systems are relatively similar. So it's not unusual, is it, for a doctor to prescribe a drug or a pharmaceutical that's not strictly for the purpose it was originally intended. Would that be correct?
Yeah, that's in fact the very first allegation against me, or accusation, was that I was prescribing an illegal, which isn't true, and unlicensed, which isn't true, product in a medical context. So first of all, the progesterone is not illegal. Progesterone has been around it's been used in obstetrics to preserve pregnancy for well over 50 years and has been very safe. So we knew that progesterone was safe. It's certainly not illegal, and it's not unlicensed. So progesterone is licensed. It's interesting. It's not licensed for use in IVF, but it's commonly used off-label, off-license in IVF. The point that I made in answer to that one was that, yes, it is an off-license use. It's not an illegal use. It's not an unlicensed use. It's an off-label, off-license, as many drugs are, especially in pediatrics, actually. But also, and I pointed out to them, misoprostol, the second abortion drug, so after mifepristone is given, which is licensed for abortion, but misoprostol is not licensed for abortion. At least back then it wasn't. I think in the last 12 or 18 months they have widened the license for misoprostol, so it now can be used, or in a licensed fashion in abortion provision. But back then it definitely was off-license use, unlicensed use. And I also pointed out, even more importantly, because the Royal College of Obstetricians was very keen to ban us from doing this, and that was their objection. In fact, I neglected to mention that even before we set up the service, we actually wrote, after I'd spoken to George Delgado and the people in the US and looked into it, we wrote to I, as president of the CMA, wrote an official letter to the RCOG, to the Royal College of General Practitioners, and to NHS England, telling them all about this wonderful service of APR and of the success rates it was having, and how safe it was, and how wonderful it was, and women were demanding it. And we wanted to become an official mainstream service, but the responses we got back were very disappointing. Not surprisingly, I suppose now. At the time, I thought they might have been more enthusiastic. But the hypocritical response from the RCOG, which was a joint letter with the RC GPs as well, joint letter, was that we do not recommend unlicensed medications or off-license use of medications. And we wrote back to them and say, well, that's very strange, because you're very keen to prescribe and recommend misoprostol, and even more importantly, you're very happy to recommend methotrexate. Methotrexate is an anti-inflammatory drug. It's quite a dangerous drug, actually, if in the wrong hands, but it's used in chronic inflammatory conditions, particularly rheumatoid arthritis. But it's also now the recommended drug for use in the medical management of ectopic pregnancy, to try and avoid tubal operations. But that still remains an off-license use of methotrexate. So we wrote back to the RCOG and the RCGP pointing this out, but pointing out maybe they had forgotten about these little details, but we got no further response from them. Not surprisingly. NHS England said that they didn't they felt there wasn't enough evidence to support its use. So it's not uncommon to use off-license use. Now, there is a proviso to that. The doctor prescribing must take responsibility, which I was very happy to do. He must be aware of how the drug works, what the actions are, because it's not unusual that when a new drug comes on the market, it's useful maybe for hypertension or for some specific condition. And then 5 years later, 10 years later, it's found actually it's used in hypertension, but it's actually very good for something else, maybe for heart failure or other conditions, which I'm certainly familiar with. So it's not unusual to discover new uses for drugs that initially will be an off-license use, and then it can, at a later stage, the companies who make these drugs can apply for a license for the use in this particular context. That's very expensive and a long drawn-out process, which is why a lot of companies don't do that, and many medications remain in off-license use for long periods of time. So progesterone is no exception. Progesterone has been around for well over 50 years, safely used for both mothers and babies in pregnancy. There's no increased risk of any side effects. It's commonly used in IVF. It's commonly used nowadays to prevent miscarriage in women who haven't taken mifepristone, but especially if they've had a previous miscarriage and they're considered to be at risk of a further miscarriage, then that is the recommended drug. And we give it in exactly the same dosage that the obstetricians recommend for preventing miscarriage. And that's really what we're doing in our abortion pill reversal. We're trying to prevent a miscarriage. The only difference is this miscarriage has been induced by mifepristone, which makes it even more likely to be successful, actually, because miscarriages can happen for lots of different reasons. Some are due to genetic reasons, and given progesterone in those situations is not going to be of any benefit, but it's not going to do any harm, and it just might work. If progesterone comes to the fore, Its best use is when the cause of the miscarriage is low levels of progesterone or failure to produce progesterone or some functional disturbance of progesterone itself. And that's exactly what we're doing in abortion pill reversal. And the mifepristone is competing with natural progesterone for the progesterone receptor sites in the female reproductive tract. The progesterone can't get in quick enough because the mifepristone is blocking it. So what we're doing is trying to give progesterone the upper hand, at least to make it a fair playing field, a level playing field that it can now compete with a good chance of success against the mifepristone that it's blocking its pathway. So this is the ideal situation. If you want to say that, yes, we can use progesterone to prevent miscarriage, this is the ideal situation where it should be strongly recommended, not just by people like myself, but by everybody across the board. Everybody in the medical profession should say, if we're going to use progesterone to prevent miscarriage, there is no more ideal usage than in this context.
Well, I think that's twofold there. I mean, a layman, I understand enough that, and I can never say it right, but the mifepristone is effectively stopping the production of progesterone. That's how it's operating. So, if you will,
stopping the effect of progesterone because it's blocking the receptors. So progesterone is still being produced, but it just can't have its effect because these receptors competing against the mifepristone, which has a stronger binding ability than the natural progesterone molecules themselves. So we're trying to, basically it's an antidote. Progesterone is an antidote to mifepristone. So just as mifepristone can block progesterone, by giving extra progesterone, we can, if given quickly enough and high enough dosage, we can block the effect of mifepristone.
And that ends this first part of my discussion with Dr. Dermot Kearney. Tune in next week where we conclude the discussion, the interview, with part 2 of the interview.